Welcome everybody to our presentation today. Thank you for joining us. We are excited to have some guest speakers here to talk about a pretty important topic, ALS and FTD. And I'll keep this short, but we will be recording this. So we will send out the recording to everybody who registered for today's presentation. If you have any questions, feel free to use the chat box. And if you move your cursor around, it's usually at the bottom of your screen. And you can enter any questions or comments during the presentations as they come up. And we will take some time at the end too to respond to some questions as well. But feel free to use that chat box for those. So if you'll also keep yourself on mute just to minimize the background noise, that will help a lot. And with that said, I'm going to pass it off to Dr. Campbell Sullivan.
Wonderful. Thanks, Steve. So hi, everyone. I'm Dr. Sullivan. I am a neuropsychologist, and we like to give this talk for families who maybe have a recent diagnosis of ALS-FTD, have some questions about ALS-FTD, but it's sort of a primer for individuals who are caring for loved ones who have this disease. And so let me share my screen with you. Can everyone see that clearly? I'm going to assume yes. Yeah, so we're calling it a primer for caregivers. And so it's broken up. I'll do my introduction here. So this is me. So I'm what's called a board certified neuropsychologist. And that's just a fancy word for someone who likes to study the relationship between the brain and the behavior. So I'm really interested in thinking skills. So patients come to see me so we can sort of give their brain a little bit of a workout to see if what they're experiencing is the effects of normal aging. With our ALS patients, we want to see if what we're seeing, might lead us to say that this is ALS with cognitive impairment or ALS with behavioral impairment, or if we think this is in fact an ALS-FTD syndrome. I work at UT Health San Antonio. I'm a director of something called the Mind Clinic. So that's just a joint clinic. I also co-direct our FTD center. And so for those who don't know, FTD stands for frontotemporal dementias, and we'll go into that a little bit later. And then I'm also at the Biggs Institute. So maybe if you've seen or heard of that before, that is our Institute for Neurodegenerative Diseases. So diseases that are going to progress for which we don't have cures. Let's see. So our overview. So like I said, this is going to be broken into two different parts. So part one is my responsibility. We're going to talk about what ALS-FTD actually is, because it's very complicated. It's complicated for families. It's complicated for patients, and a lot of times it's complicated for your providers. So I still have, practicing physicians who will call me and like, can you just give me a quick rundown of sort of what this is? So you're not alone if you're confused. It's confusing. And then we're going to talk about caregiving, because we know that ALS-FTD has a higher burden of caregiving, or higher burden on our caregivers. And so we want to support you as much as we possibly can. Step two, or part two, that is going to be taken over by our fellow friends and colleagues, the Reynas. And so they are lawyers in town, and they're going to talk about sort of crucial steps for caregiving, sort of future planning, and the importance of completing your paperwork. So that's like getting wills and everything in order, because that's important especially for patients who are newly diagnosed. All right, so if we think of ALS and FTD on a spectrum, one end of the spectrum, we have the diagnosis of ALS, right? And we have a lot of information online about this. So it's also called motor neuron disease. So these are patients who it's a progressive disease that attacks the motor neurons in the brain or the spinal cord. And these patients have muscle wasting. They have loss of movement. They might have trouble swallowing. And that's sort of a very classic presentation of ALS. And where we see those motor neurons attached sort of is where it presents in the body. So sometimes patients present with the muscle wasting or the loss of movement in their upper extremity or their arm. Sometimes it's in their tongue or their throat, those muscles. So that's sort of ALS. On the opposite end of the spectrum, we have FTD, and that's frontotemporal dementia, so the front part of the brain. Now, this is a neurodegenerative disorder, so that means it's progressive. So it starts, and it's caused by bad proteins that build up in the brain. And there's a lot of different types of proteins, and we don't know what causes them. And they're not proteins that we eat or anything. It's proteins that our body makes, but for whatever reason, they attack the frontal part of the brain. And frontotemporal dementia can affect sort of three main things. So we see changes in behavior or personality. We see changes in someone's language. So maybe they can't understand us as much anymore. And we see changes in their movement. So, they're not walking as clearly, or they're having tremors, or they're having involuntary movements. So those are sort of the classic presentations of frontotemporal dementia. So they're opposite ends of the spectrum. But sometimes in some people, we see a little bit of both diseases in the same individual. And so for those people, they get a diagnosis of ALS with FTD. You might see it referred to as motor neuron disease with frontotemporal dementia. You might see it flipped. Some people say it's FTD with ALS, because it used to be that if you diagnose the FTD syndrome first and then the ALS developed, that would be a way to distinguish it. So right now, the nomenclature, the words we use to describe it, it's a little bit all over the place. But for the purposes of this talk, I'm going to refer to it as ALS-FTD. And that just means we're having symptoms of ALS, so that muscle wasting, that loss of movement, that trouble swallowing, and symptoms of frontotemporal dementia. So changes in behavior, changes in language, or changes in movement. We're having that in one individual. Now, a lot of times people hear the word dementia and they don't quite know what it means. And they'll say, oh, it's okay, I have dementia. It's not Alzheimer's disease. Or they think Alzheimer's disease is dementia. And then we have this frontotemporal dementia. What does that really mean? So again, there's a lot of confusion here. So I want to give you a little bit of context into what I'm talking about when I say dementia. And so dementia is considered an umbrella term, right? It's a diagnostic term. We use it to sort of stage people where they are. And all dementia means is that you're having cognitive impairment. You're having changes in your thinking skills. And when we compare your performance on certain tests, when we compare you to other people who are very similar to you, so people of the same age, the same level of education, the same background, if you are not performing where we would expect you to be performing compared to your group, then that lets us know that there's some changes going on in the brain. That lets us know there's cognitive impairment. So maybe your memory is not as good as other 62-year-old men with a college education, right? You might be underperforming when compared to your group. So if we see cognitive impairment plus declines in function, those are the two ingredients that are needed for a diagnosis of dementia. So your memory impairment is poor on testing when compared to your group. And we're seeing that because of that bad memory, you forget to take your medications as prescribed. And so maybe your blood pressure goes up, or maybe your sugars are going up and they're not as well controlled. So it's the changes in the thinking and the changes in your daily independence. Those are the necessary ingredients for a diagnosis of dementia. Now, we have patients who have ALS, who have some changes in cognitive impairment, but they don't have those declines in daily function because of that cognitive impairment. So they may not be able to physically get the medications to their mouth, but they remember that they need to take the medication, and they remember what medication they need to take. So that might be someone who has some cognitive changes, but not that decline in function due to those cognitive changes. So that might be someone with ALS with cognitive impairment. But if we have someone who has ALS with the cognitive change and decline in function, that's going to be a patient who has ALS with dementia. And then we'll go on further. If we have someone who has ALS with FTD, we're seeing changes in cognition, as well as changes in motor, changes in language, and changes in behavior. And what's tricky about this is that the individual can have any combination of these symptoms listed below, and it will still meet criteria. So ALS-FTD is not a single thing. Just because you have that diagnosis, you could look very different from someone else. So some of our patients with ALS-FTD might have significant problems with apathy. They don't want to do anything. They kind of stay, sit on their own a lot. Can't get them motivated to do things. They might have changes in judgment. So they're not making good choices. They're spending lots of money. They may be a little bit more compulsive. We're seeing that they have trouble with, working memory and tests of executive function. So that's more of a cognitive change. And that would be someone with ALS-FTD. Conversely, you can have someone whose memory is really strong, but for whatever reason, they're hallucinating. They think that there are bad people out to get them. They feel like they're not safe in their home at night, and they're having these changes with motor symptoms with ALS. So again, the ALS-FTD spectrum, it's any number of these symptoms presenting in the same person. I will say that apathy is the most common symptom for both ALS and FTD. And for our patients who have ALS-FTD, apathy is also really, really high, okay? But you see the changes in behavior can be very challenging. And as you sort of move on that spectrum from ALS to FTD, we start to see more changes in behavior. So remember the behavior. We're going to come to that a little bit later. All right, so I mentioned this earlier, executive dysfunction, and we're talking about frontotemporal dementia. So this is a picture of the brain. I don't think you can see my cursor, but this little tail at the bottom, that's sort of the back part of the brain. And that big part, that's going to be the front part of the brain. I think I have a little circle. There we go. So that's the front part of the brain. Those are the frontal and the temporal lobes. And think of your frontal lobes, if it were a business, or if your brain were a business, your frontal lobe, that's going to be the CEO of your brain. That part of the brain is responsible for prioritizing things, for multitasking, for processing things quickly, for understanding. It's also responsible for like recognizing emotion, recognizing, uh-oh, I said something I shouldn't have said. Recognizing when you should apologize, when you should sort of walk away. So that area of the brain is really important just for day-to-day activity. And when we start to see atrophy, or we start to see that front part of the brain is shrinking, that's when we start to see a lot of these changes. And so our ALS-FTD patients often will have poor judgment. And that's tricky because when they come in for clinic and Dr. Jackson might make a recommendation, they don't recognize or appreciate sort of the severity of the disease. And they don't appreciate the gravity of the situation. And so because of that, they might decline life-sustaining treatments. We see this most often with PEG tubes. So patients are having changes in their frontal lobes. They're not making good choices. They're not really recognizing how severe the situation is. They're kind of downplaying everything. Dr. Jackson says, we think you need a PEG tube. This is going to sustain your life. This is what you want to do. No, I don't really need it. And it's not because they're in denial, and it's not because they don't want to sustain their life. It's often because the part of the brain responsible for appreciating the severity of the situation, that part of the brain is taking a hit. So that part of the brain shrinks and it's not it's not working as well as it once was. So our patients also will have trouble with multitasking. Things get a little bit slower. So they might be slower to process new information. They might be slower to come up with the right word. They might be really inattentive or distractible. They might be saying inappropriate things in public, going up to strangers in public. We often see changes in appetite. So when people can still eat, they're having really restricted foods that they want to eat, and they might be craving more sweets and more carbs. So some people have what's called a food fad, and so they just want to eat a singular food all day long. So I had one patient who just loved popcorn shrimp, and he just ate popcorn shrimp for breakfast, lunch, and dinner. I have other patients who are really, become sort of compulsive and start eating lots of sweets, like ice cream is a big one, or like Little Debbie's. I had one patient who just came in and had all his pockets were just filled to the brim with Little Debbie's, and he would offer you one. So, there's definitely changes in that, that sense of satiety. So they might eat more than they ever did before. So they're eating beyond the point of feeling full, and just sort of like eating way too much. And then some people are disinhibited, and then others will have that anosognosia. So these are patients, this is challenging, where they don't recognize that anything's wrong. They don't recognize, or they don't agree with the ALS diagnosis. They don't agree with the FTD diagnosis. They might have lots of reasons to sort of explain what's going on with them, but there's no amount of arguing or logic that can really reason with them. They just can't appreciate these changes. And that can be really challenging with, as the disease progresses. Speech changes, a lot of you guys will be familiar with these. So many of our patients have slurred or garbled speech. They have agrammatic speech. So they're just saying the most important aspects of the sentence to communicate their thoughts. We might have stammering. We might have word finding difficulties. The language, that's a little bit more challenging. So speech is how we're saying what we're saying, right? My ability to pronounce the words accurately, that's my speech. The language, those are the words that I'm using. Sometimes our patients lose the meaning of the words. And you might notice this, that if you're speaking to your loved one and you're using sort of long sentences or using sort of more, sophisticated vocabulary, they don't fully understand what you're trying to say. You might have to simplify things. You might have to shorten your phrases so that they understand you. We have some patients who just have empty language. So it's really hard because we don't know what they're trying to communicate. So they're talking a lot. Their speech is really accurate. You can understand what they're saying. It's very well pronounced, but those words just don't go together. And so that can be challenging because we have trouble communicating or understanding what it is that they need. And then we have the movement symptoms. So if it's a limb onset, like I said, we have the muscle weakness, the clumsiness, the reduced dexterity. If it's a bulbar onset, those are the patients where we have trouble speaking, trouble swallowing. Sometimes patients will have something called pseudobulbar affect. That's just a long word for individuals who start to laugh when they don't feel that something is particularly funny. It's just sort of that like motor response, or they start to cry when they're not really sad. And so it's sort of this overflow of emotion. And if that happens, go see your neurologist, and they can often prescribe something to help with those symptoms. So the genetics of ALS, 90% of ALS is sporadic. And that means it just happens. We don't know why it happens. It just happens. 10% of ALS is what's called familial. And so that means it's inherited. So someone in the family passed along a gene that caused the ALS to happen. And if we look here, that tiny 10% cheese wedge makes up this entire circle next to it, okay? So in that tiny 10%, these are the biggest genes that are known to cause ALS. So the biggest one is the C9 mutation. So that's C9 or 72. And that's the one that really led to this discovery that ALS and FTD were on this sort of spectrum. And you can see aspects of both diseases in the same person. We also have things called SOD1, TARDBP, we have FUS, we have unknown genes of significance. And so there's a lot here, but really what most of the research focuses on are these C9 mutations, just because it's the most prominent. And just as ALS genes. So the heritability, how do you inherit something like this from your family? So most of these genes are autosomal dominant. So that means that there's sort of a 50-50 chance that you're going to get a copy of the affected gene. So we see here, we have the affected father, and he has two sets of genes, one normal, one abnormal. We have the unaffected mother who has two normal genes. And as you reproduce or have children, you're going to give one copy from each parent to create that child. And so children, you can see it down below, there are 4 children there. 2 of the children will have the affected gene. 2 of the children will not have the affected gene. So a child of an individual with a dominant mutation has a 50-50 chance of inheriting the copy of the gene. All right. Okay, so that's sort of a long-winded introduction to ALS-FTD, but really what I want to focus on are caregiver challenges, because we have demonstrated that caregiving is hard and that changes in cognition and behavior place a heavy burden on caregivers. We know that. But what's tricky with ALS-FTD is that you guys have the added burden of dealing with these cognitive and behavioral changes while simultaneously combating rapidly progressive physical declines. So you're essentially getting like your RN degree because you're learning how to manage a lot of these, equipment that most patients with dementia never have to deal with. Most patients with dementia don't, get peg tubes. They don't use Hoyer lifts. They don't use, electric wheelchairs. So it's a double whammy. And we recognize that, and it's really hard. So, your daily responsibilities are you're learning to manage this medical equipment for your loved one. You're also assisting with decision-making. And that's hard because you don't always know, is their judgment compromised? Is this what they would have wanted 10 years ago? Is this the disease talking? It's really challenging. You often have to supervise medications and daily activity to ensure safety, maintain their treatment adherence. And what we found is that caregivers for patients with ALS-FTD are 3 times as likely to report high levels of caregiver burden when compared to other dementia syndromes. So caregivers of loved ones with Alzheimer's, they don't have the same level of burden that you guys have to deal with. So there's a recent study that looked at 55 families living with ALS. 18 of those patients were diagnosed with ALS-FTD. So again, it's just a small portion of the community. 41 were diagnosed with ALS only. What they did is they divided the group into high levels of caregiver stress and low levels of caregiver stress. The single most influential factor to predict high levels of caregiver distress was a diagnosis of ALS-FTD. Our preliminary research, what we're looking at in our clinic right now, we're finding very similar results. And the added burden of any behavioral changes, so those changes in judgment, that inability to recognize that you have a disease, psychosis, that is the single most influential factor of predicting high levels of stress for caregivers. But what's interesting in this study is that they had some families who are caring for loved ones with ALS-FTD who had low levels of caregiver burden. So that's the group we want to study. What are those families doing? How can we help all of our families get to that point? And so what they found is that it's based on your coping style. So in the world of caregiving and coping, there are 3 styles, that directly relate to your stress. So some patients are some caregivers are very task oriented. So they're actively involved, they're planning, they're supporting, they're there, they're in it. We have other families, they're more emotion oriented. So they use humor to sort of deflect from their feelings. They try to be really positive. They might just sort of put all their faith in God. And then we have other caregivers who are very much avoidance oriented. And so they're disengaged, they're in denial, they kind of self-distract, they might blame themselves, they might sort of, escape into substance abuse, they might just vent about their problems. And so, and not everyone is one style all the time. But what we found is that patients or caregivers who were focused more on the task at hand had better outcomes and lower levels of stress. Patients who were avoidance oriented had higher levels of stress, because that stress, if it's just there, we're kind of burying our heads in the sand, it doesn't go anywhere. And it just kind of gets bigger and scarier, and we don't really know what to do with it. So how do we get our families into that sort of action-oriented caregiving style or coping style? And what we found is number one is education. The more you can learn about the disease and what to expect, the better you feel, or the more caregivers feel able to manage what's coming. And then we also need to provide emotional support. So that can be through individual therapy. That can just be time with family and friends who are supportive. It can also be participating in support groups, either online or in person. And so our ALS Association in Texas, I hope you guys have looked at their website online, because it's pretty incredible. And so they have a lot of opportunities for you guys to sort of educate yourself, but also to be involved and to connect with other caregivers. The AFTD Association also has caregiver support groups. And so, if we're dealing with both ALS and FTD, you can kind of get the benefit of both associations and participate in all the support groups. So the last thing, actually, almost running out of time. So we also, at our clinic at UT Austin, we're launching a new program for families who are dealing with ALS-FTD, and that we're going to see how that helps support you and helps get you into that more task-oriented style of coping and managing with the disease and managing your loved one. So look forward to that. But the one thing that I think comes up most often in my clinic is nutrition, feeding tubes, and judgment. And so I mentioned it earlier, is a lot of our families or a lot of our patients don't really appreciate sort of the severity of the disease, or they don't recognize how advanced their disease is, or how, they might need a PEG tube to sustain their life and to reduce the risk of aspirating or choking on food. And what we found is that when you can't eat and when you can't get good nutrition, that contributes to fatigue, that contributes to confusion, increased muscle loss, and increased caregiver burden. It's really hard to watch someone aspirate, really hard. We've seen it in clinic a few times. And so, we have these things called PEG tubes that can be very helpful, and they kind of bypass, the throat, go down into the tummy. And so patients can get their medications, patients can get their nutrition, and it's definitely, helpful in sort of reducing a lot of the symptoms of poor nutrition. But when you have someone who has ALS-FTD and they don't recognize that they have a disease and their judgment is compromised and they're making poor choices, getting an individual to agree to a PEG tube can be very challenging. And so that's why as soon as we get a diagnosis, I encourage families to start talking about these later steps in the disease process, so that when we get to that point, you already have a plan in place. All right, so that's sort of a nice introduction to ALS-FTD, into what it is, into sort of the concerns for caregivers. We've learned that in order to take care of the patients, we have to take care of you guys. If you guys go off the rails, everything falls apart. And so that is why we're launching these sort of primers, so you guys have a better understanding of what the disease entails. And then we're going to follow up with more caregiver interventions. At least for now, we're doing this at UT Health in San Antonio. But the second part of the talk is also really important. I encourage you all to sort of stay for that. And that is going to be from our lovely lawyers to talk about the importance of estate planning. And I will stop sharing my screen if I can. And there we go.
Great, thank you, Dr. Sullivan. I think that was my third time to hear that presentation. I always learn something new every time. Hi, everyone. Good afternoon. My name is Austin Reyna. My wife, Jackie Reyna, is also here. We're both attorneys here in the San Antonio area. And just like Dr. Sullivan said, today we're giving a brief overview of what we think is most important and what we recommend. Really, where do you want your stuff to go, and how that process works when that end of life comes. Just as a little precaution, we always have to do this is, the lawyer, the legalese is, while we really intend for this to be very beneficial, we've worked very hard on it. At the same time, each situation is very individual, and we recommend that after this, you're going to have the ammo, you're going to have the questions to go ask an attorney what's right for you. Briefly about me, again, my name is Austin Reyna. I work at the Fourth Court of Appeals here in San Antonio. Went to Texas State, graduated from St. Mary's Law. I'm licensed in Texas and fairly a few places. Really, what brought me and my wife to the attention here is my mom. She was diagnosed 2 days before Christmas in 2019. And sadly, she passed away in February 2021, right after the snowstorm. It was bulbar ALS, and it was quick. But from that process, we really understood what's needed and how can we help. I'll say, when my mom was first diagnosed, she didn't have a medical power of attorney. And so my dad and I had to go through and figure out, because at that point she couldn't use her hands. And so we had to figure out what is needed. And Jackie and I's hope is that doesn't happen to someone else. And Jackie, not only is it her birthday today, but she's an amazing lawyer, an amazing person. She works at Her Law Office, where they particularly do wills and estates, probate, and family law. And actually, 2 days before my mom was diagnosed with ALS, her grandmother passed away from ALS. So it's a cause that's really near and dear to us, and we hope this talk is helpful. So briefly, this is going to be a grand overview of what do you need, what you need to ask. A lot of times, and Jackie can speak to experience of this, a lot of people will come in and say, I need this, or I have this document. I got this off of LegalZoom or something like that. Is it valid, or does it work? And a lot of times you don't need that many type of things. You need really what's important, and Jackie's going to get more into that later on. But I'm going to start with what's called do not resuscitates. A lot of times you'll hear people briefly call them DNRs. And do you need one? Technically, no, but for someone with ALS, I highly recommend it. It's something that it's not gonna. It's really what it comes down to is if you're in a situation, if you don't have a PEG tube and you are in need of emergency care. Do you want to go? Does your loved one want to go naturally, quote unquote, or do they want someone to provide everything they can? And that decision, I highly recommend that you talk with your loved one early on and make, so it's not something that is done in the moment rationally. And so if this is signed, then what will happen is when EMS comes, they'll give comfort. They'll provide medication to where they're not in pain, but they will not provide life-saving measures. Importantly here, again, you can't just get it off of the internet, sign it, and you're good to go. Not only does it have to be signed, which we'll talk about later, there's some things you can do if your loved one can't use their hands or they can't physically sign. We'll get to that later, but it has to be signed, and there has to be a qualified witness or a notary. The easiest will probably be a notary, but if you have two people there with you, then that will work as well. And I'm going to pass it off to the birthday girl to handle some directives.
Thank you, Austin. So I'm going to talk about a few of the directives that we normally recommend, and by we, I mean my firm here, that we normally would say is the best way to go. So we're going to start with the power of attorneys. There's two types that we normally provide here and that we recommend. There's also the there's also the directives to physician and to family, which honestly, the medical power of attorney is actually a bit broader and covers more, and we don't do the directives as often here if we have clients who do a medical power of attorney. But I'll talk about those as well. Okay, so an overview of this is just with power of attorneys, there's a statutory durable power of attorney, which can control your finances, any type of perhaps personal care or items that you need, right? There's also the medical power of attorney, which would be for your medical care. And then what each of the documents can and can't do. So I'll go a bit more into that. Okay, so the question is, what is a power of attorney? I have a lot of clients who come and see me who have no idea what that is. They came in for a will, or they came in because they think a trust is what they need, and they didn't even know what a power of attorney was. So a power of attorney is a legal document that gives another person the legal power to act on your behalf while you're still alive. It is only in effect while you're alive. At your loved one's death, it is not in effect anymore. It's done. And so it cannot be used after your loved one passes away. Now, the person that's appointed in the power of attorney is called the agent. And the person who signs a power of attorney that makes someone else their agent is called the principal. And now the person that you appoint as your agent does not have to be an attorney. Usually what I've seen is it is a loved one, a child, or a spouse. And if that person does not have a child or a spouse, it's normally a sibling or somebody that they, trust with their life. A hiccup that I will say that I have seen recently is I had somebody come in who had a power of attorney, and they went to their bank, and their bank said, unfortunately, we can't accept this, because they looked into the agent, his history, and he had some financial issues. He had filed for bankruptcy and possibly had some credit issues. I'm not sure, but for the statutory durable power of attorney, aka the financial power of attorney, certain places can reject it if they have a policy internally that says, oh, we looked into this person's history and they have some background issues that we don't want to mess with, right? So they have the authority to reject even a perfectly drafted power of attorney if they have an internal policy that says we can't accept this. And so that's just an issue I ran into recently that I wanted to make y'all aware of, that if you do have a person as your agent, you need to make sure that they will be acceptable in that way. So what do you need for a power of attorney? Again, the person you trust with your life and sound mind, and we will go into that a bit more. So what does sound mind mean? So sound mind means when the person is in the office and I hand them the paperwork and I explain everything to them, that they're able to understand the effect of that power of attorney, that what it's going to do. and that person will be able to act on their behalf, and the extent of actions that person will then be able to take on their behalf once a document is signed. So they need to understand what is happening at that time. So for example, probably a person in the later stages of Alzheimer's cannot sign a power of attorney. If I ask them questions, and they don't know what they're signing, or they maybe don't know what day of the week it is, who the president is, the year, I ask those sometimes if there's maybe a question of that type of issue. Okay, so the basics. So the biggest one is going to be the statutory durable power of attorney. And again, this would be for your finances and personal maintenance. I can't stress enough that this is a very powerful document. There's two ways that you can, I guess, have it be in effect. So you can have it in effect immediately once you sign it, which is what our firm normally would recommend. The second way is upon your loved one's disability and incapacity, it's in effect. Now, the second way, the hiccup there is that you need to have a doctor's note or authorization that basically declares this person is incapacitated, they can't sign this. And if there's anything that needs to be done right away, that could take time. So what I would recommend is that you have it be effective immediately and not wait until you're declared disabled or incapacitated. But they're both legally fine. Legally, you can do both. And then I've heard stories where a person has it in effect immediately and they call and say, my daughter took all my money. Because again, it's very powerful. But if that's the situation, that goes more towards who they pick as the agent, and maybe not the document itself. So you want to make sure the person that you pick, again, is somebody that you trust with your life. And then the medical power of attorney, this would authorize an agent to receive and make any medical choices on your loved one's behalf. And it typically does become effective immediately once it's executed. The only, you do need 2 witnesses and a notary, but you cannot, the witnesses cannot be in charge of your health care or have any type of stake in your estate. So that's definitely one that you would probably want to have executed at a lawyer's office. And that's something I'll go into a bit more later. Then there's the special power of attorney, and this special or limited power of attorney, which I don't do too often. I don't really have too many who want this particular type, or it's not needed, I guess, in their situation. But the powers with this are limited to only a specific situation or area, like if the principal wants to sell a house, but they're not able to be there. Or for example, my husband and I, I'm 6 months pregnant. And once we have our child, if we leave to go on a trip or something, we're out of the country, I would probably do a special power of attorney so that my mom can be the agent and make any choices for our child while we're away. So in short, it starts and stops at different times. Okay, so the next logical question would be, what can a statutory durable power of attorney actually help me with? Like, what's the point of me signing one? There's all these rules, and, my agent can't have any bad credit, and some places don't even accept them. Like, why would I get one? Well, it's important for a number of reasons. You need this to access the principal, your loved one's financial accounts, if you're not already on there, to pay for healthcare, housing needs, and other responsibilities that they're not able to take care of at that time. File taxes on behalf of the principal, make investment choices on behalf of the principal if they have a trust or something set up, collect any type of debts, manage their property, and also apply for any type of public benefits for that principal on their behalf, like Medicaid or any other type of benefit. Now, the medical power of attorney, that can control what care the principal receives, including hospital care, surgery, psychiatric treatment, home health, which doctors and care providers the principal uses, where the principal lives, including long-term health care like assisted living, medical care, nursing homes for medical purposes. So there's those two types of situations, and that's why they're so important and useful, especially, and for the medical, especially if there's not really like a next of kin or somebody there who the hospital or the agency is okay with to say, yes, that's fine. If that person doesn't have those people in their life, then they probably need a medical power of attorney. I've heard some stories of some hospitals saying, oh, your next of kin, it's fine, but you don't know, there's a lot of other stuff that you need, and not every place will say that. A lot of places want you to have a medical power of attorney. Those are just more examples of powers in the statutory durable that we normally have listed, like real property transactions, which if you want your agent to do that, you need to have that filed with the deed of records of the courthouse where your property is located. Tangible personal property transactions, I'll let y'all read that, but pretty general, but that's typically what the statutory can do. What can't a power of attorney do? Can't change a principal's will. I think I've seen some where that's an option, to change a trust or make a gift. We don't recommend that. We really don't, because that could just be very complicated, especially if there's maybe some other siblings involved or children that would not agree with that, and that could just cause problems later. They can't break their fiduciary duty to act in the principal's best interest. Basically, everything they do, it has to be for the benefit of the principal, like they're doing this because the principal, can't act at that moment, at that time or that moment, they can't do those things. So if they, pay themselves or they steal money, then that's not what the power of attorney is for. Make choices on behalf of the principal after their death. Again, don't think if you just have a power of attorney, you don't need a will. The power of attorney ends on the death of the principal. It's only active while your loved one or the principal is alive. Change or transfer the POA to someone else. Usually in our power of attorneys, we have an alternate in case the first choice for agent does not want to or is not able to qualify. So they can't just say, well, I want my wife to, and the wife's not named in the power of attorney. I have an example there, you can just read it because I think we're running out of time. So the durable power of attorney is a writing that designates an agent must be signed by the principal in the presence of a notary. And again, we already discussed this. You can pick from one of these two options. It either starts immediately, which is 1, the power of attorney is not affected by subsequent disability or incapacity of the principal, or 2, this power of attorney becomes effective once the principal is disabled or incapacitated. And again, we don't normally recommend that for clients because again, if you have to wait for a doctor to say they're incapacitated, it's effective, it may cause some unnecessary delays. Medical power of attorney, same kind of concept, signed in the presence of, except it does need to be signed in the presence of 2 competent disinterested. Again, they can't have any help in your medical care. They can't work for the hospital, and they can't have a stake in your estate or anything once the person passes away. And the witnesses will sign. And we normally have 2 witnesses and a notary for ours, just to make, be extra safe. These are the directives. We always have a lot of people that ask about these, but the medical power of attorney should cover it, because the directive will basically only state that in the event that I'm in a terminal condition and I'm unable to make those choices for myself, I request that all treatments besides those keep me comfortable be discontinued or withheld, and I pass away as gently as possible, or I request I be kept alive in this terminal condition with life-sustaining treatment. So that's what the directive does. It just says, yes, keep me alive however possible, or no, please let me pass away. I also, when we do the medical power of attorneys, we recommend that you sign a HIPAA form as well. And it has a list of people who you're okay with receiving your medical information. And for that, you need a competent adult, sorry, but you go back one, sign in the presence of 2 witnesses or a notary, and you can notify your doctor of this form.
So I'm going to take over the wills here, and I'll be pretty brief. I know we're running out of time, but one thing I do want to highlight is that I didn't forget about, I want to come back to, is the conscience presence test. And in Texas, I mean, and as we know with this disease, sometimes the first thing to go are your hands, and you can't write, you can't do what you used to be able to do, hold a cup. And so what's great about Texas is we follow the conscience presence test. So what that means is, as long as someone has a sound mind and it is by their direction that someone signs for them and they can see it happening, then that is valid in the state of Texas. So for instance, another great thing too is anything that person adopts as their signature is valid in Texas. So just because I have one signature now, and if later on I couldn't do that signature because of an ailment or something like that, but I had a sound mind, I was in the presence of Jackie, and I told her I wanted a line with a dot to be my signature, and I adopted that as my signature, then that's a valid signature, and that will apply to wills and directives. So for traditional wills, they are, a lot of people get them off these online places, and they don't have the technical requirements, and these are very hyper specific to your situation. So I'm not going to spend a lot of time on these wills, but I recommend that if you do want a formal will, that you go to a licensed attorney in your area and go with the big stuff. What do I have? Where is it? Who do I want to give it to? If you have those 3 questions answered and you go to a licensed attorney who practices in wills and estates, they should be able to draft a will for you and walk you through the steps of, okay, this is how we need to have it technically executed, and your stuff's gonna go where you want it to go. What I really want to focus on is holographic wills. Now, while traditional wills need to be signed and they need to be fully in writing and go through all these technical requirements, a holographic will does not. All it has to be is wholly signed in the person's handwriting, and it has to have testimony intent, meaning I, Austin Reyna, give everything to my dog, Rocky Reyna. Well, it can't be a dog, it's a bad example, but I just want to see Jackie's face. I, Austin Reyna, give everything to my wife, Jackie Reyna, upon my death. I sign it. It's completely in my handwriting, and that can be probated as a will in Texas. One of my favorite stories in past law school of the case we read, where a farmer was on his farm. I don't know how this happened, but he got ran over by his tractor. So he's under his tractor. He knows he's going to die. So what he does is he takes out his pocket knife and he writes into the bumper, this is my last will and testament, says who he wants to give his stuff to, signs it, and he dies. So what happens is they take that bumper into the courtroom and they probate it as a will, because that's a valid will. It was completely in his handwriting, signed by him, and had the testimony intent. So if you're at a point where you might not have time to get in and you're so busy, but your loved one can still write, I highly recommend the holographic will as an option. And with that is our presentation, and I believe Linda's going to give out our information, Jackie's information, if you have any further questions. And I'll stop sharing and pass back off to you, Linda. Oh, you're on mute.
Oh man, I was so close not doing that. Well, I just want to thank everybody for being here and for doing the presentation. We greatly appreciate it. If you do have any questions right now, you are welcome to put them in the chat box. I know this is going to be recorded, so the email that you use, definitely it will be sent to your email. We will have some follow-up information for Jackie and Austin, like he said. For Dr. Sullivan, please let us know if you have any questions, and we can definitely get those to her. As you're seeing on the screen, next week we are going to have a connection group for caregivers who are currently living with someone with ALS and FTD. This group is going to be more of an open kind of troubleshooting things that Dr. Sullivan will be leading up. So again, we appreciate you being here and our guest speakers for taking the time out of their schedule to do it. And I just want to double check the chat one more time. I'm not seeing anything, but again, if you have follow-up questions, please reach out to us. Hope everybody has a great rest of the day and a good weekend. Thank you again.
Thanks, Linda.